And now I have the pleasure to introduce my dear friend, Professor Christoph. He's a professor of atherosclerosis research in the Medical University of Vienna, Austria, and he is very eminent in immunity and inflammation. Christoph?
Thank you very much. Thank you, Ashraf and Atef, for inviting me to this wonderful meeting here. It's really a pleasure being here again. Well, I will continue on the theme of inflammation and point out a few aspects that I believe will become interesting in the future, as Andreas alluded to already in his talk. So when we look at the role of inflammation in cardiovascular disease or atherosclerosis, we know that this has been something that we were working on, our community was working on for decades, and initially was started by the discovery that inflammatory cells infiltrate atherosclerotic plaques. But key milestones in this endeavor was was the fact or the discovery that systemic markers of inflammation such as C-reactive protein or interleukin-6 are associated with high cardiovascular risk, and there are also the genetic evidence supporting these findings. Now, this has led eventually to clinical intervention trials that showed that indeed inhibiting inflammation is beneficial. And as we heard before, one of the central targets for these anti-inflammatory therapies has been a cytokine that is associated with the NLRP3 inflammasome, because it has been shown that this is directly linked to dyslipidemia, as oxidized LDL and cholesterol crystals have been shown to trigger inflammation via producing interleukin-1 beta, and that is a pathway that is sort of involving many different intracellular steps, two major steps that eventually lead to the formulation of mature interleukin-1 beta. Of course, interleukin-1 beta, as we heard before, has many pro-atherogenic effects that can be mediated by activating endothelial cells or smooth muscle cells or macrophages, by producing matrix metalloproteases that can lead to the formation of vulnerable plaques or the plaque rupture eventually, and therefore blocking interleukin-1 beta can have many different beneficial effects, among others, not only beneficial effects directly in the vessel wall, but also inhibiting inflammation that, for example, is mediated by the liver. And so the landmark trial that has really shown that anti-inflammatory therapy is beneficial has been the CANTOS trial, in which it was tested whether inhibition of interleukin-1 beta with the monoclonal antibody canakinumab has an effect. And here it could be shown that indeed in a dose-dependent effect, canakinumab treatment prevented inflammation without affecting the lipids, and that eventually led to reduced cardiovascular endpoints. Of course, all of you know at the first look in this study, there was no effect on cardiovascular mortality. However, when the patients were stratified into those that really responded with reduced C-reactive protein after canakinumab treatment, there was a very significant effect on cardiovascular mortality as well. So who are these patients now that respond to anti-inflammatory therapy the best? And there recently, a lot of attention was given on a condition called clonal hematopoiesis of indeterminate potential, or CHIP, which is an age-related condition that is associated with acquired somatic mutations leading to clonal expansion of hematopoietic stem cells, and these are typically found as mutations in transcriptional regulators such as DNMT3A or TET2. Now, as you can see, these rise with age, and you have, particularly in very old people, a large frequency of these CHIP mutations. But what Ben Ebert discovered a few years ago is that carriers of CHIP are associated not only with an increased risk of eventually developing hematological malignancies, but also with a 40% increased risk of cardiovascular disease. And this is mediated in part by the fact that these mutations make macrophages more responsive or more inflammatory, particularly also in this NLRP3 interleukin-1 beta dependent pathway. So mutations in macrophages result in more interleukin-1 production, but there's also other mechanisms such as more active neutrophils that are more thrombogenic because they release more of these neutrophil extracellular traps. So therefore, Swenson and I'll ask the question whether patients who carry CHIP or have CHIP benefit more from anti-inflammatory therapy. So they did a sub-analysis and sequenced in 3,500 patients from CANTOS and looked for the presence of CHIP or clonal hematopoiesis and found that more than 8% of these individuals had in fact clonal hematopoiesis. And you can see at the age distribution here on this curve that it was even higher in younger patients than in the general population it was originally shown by Van Ebert and others. Which is obvious because there was a pre-selection of high-risk patients into this group. Now, when they then stratified these patients according to the presence of CHIP or TET2 mutations particularly, or the absence of it, they actually could see that only those individuals or patients that had TET2 CHIP mutations are the ones that significantly benefited from the anti-inflammatory therapy, whereas this was not the case in those patients where that two mutational CHIP was absent. So somatic mutations in CHIP in general predisposes to higher inflammation and make individuals more eligible to anti-inflammatory therapy. More recently, it was actually also found that there's also germline genetic variants in the NLRP3 inflammasome that predispose individuals to higher inflammatory responses. So Schunk et al. Identified a single nucleotide polymorphism in the NLRP3 gene that results in higher expression of the NLRP3 inflammasome, that sensor of the cholesterol crystals in macrophages. So when they looked at macrophages or monocytes from patients and stratified them according to the genotype, they could see that those individuals that had the homozygous for this minor allele associated with high expression of LNP3, they had high expressions of LNRP3, but they also had higher markers of inflammation in the circulation. And importantly, those individuals that carry homozygously that specific genetic variant were more susceptible or had higher cardiovascular mortality, both in Lurik as well as in UK Biobank. Interestingly, particularly in those where also other risk factors such as high levels of uric acids, also activators of the inflammasome or triglycerides were present. So there's also a genetic predisposition to be more susceptible to inflammation triggered by uric acid or by cholesterol crystals, and this again could contribute to individuals that may benefit more from the anti-inflammatory therapy. So in addition to CANTOS, you obviously know also the colchicine trials, both in stable chronic coronary disease patients as well as post-MI, have shown to be beneficial, and a recent meta-analysis has actually shown that this is the case when you look at these with a significant reduction of myocardial infarction, stroke, coronary revascularization in Colcott. Significance was primarily driven by these two phenotypes, and why the cardiovascular death was not significant in the meta-analysis, we know that from the Lodoco trial there was a clear significant effect there. And here again, colchicine could affect the inflammasome, and that could be one of the ways how colchicine is anti-inflammatory, but there's also many other ways, as we heard today, how colchicine can be beneficial by inhibiting, for example, activation of neutrophils. So more recently, in addition to the interleukin-1 beta and inflammasome-derived cytokine secretion, a lot of attention was put on another downstream inflammatory cytokine called interleukin-6. And as you know, interleukin-6 levels are associated with a significantly increased risk for cardiovascular disease. And for many years, we have known that there is actually a genetic variant in the interleukin-6 receptor, which is resulting in impaired signaling of interleukin-6 through this receptor and therefore reduced inflammation levels and fibrinogen levels. And it has been shown that in Mendelian randomization studies that individuals who carry this IL-6 receptor polymorphism are actually to some degree protected efficiently, significantly from coronary heart disease. So that's a genetic experiment telling us that inhibiting IL-6 could be a beneficial approach. And indeed, and a few studies have actually already tested this. in a placebo randomized double-blinded control studies in using an antibody, tocilizumab, against the interleukin-6 receptor that have looked at outcomes such as cardiovascular risk factors in non-STEMI patients, STEMI patients, and rheumatoid arthritis patients. And there was clearly an effect on inflammation that was lowered in these studies. But there was also a signal that actually interleukin-6 receptor inhibition resulted in a dyslipidemic profile, higher triglyceride levels, higher cholesterol levels, and so on. So Paul Rittger now more recently has now looked at a different way to inhibit interleukin-6 activities using an antibody called ziltivekimab, that is an antibody against the cytokine itself, interleukin-6, and has tested the ability of IL-6 inhibition on inflammation in patients with moderate to severe chronic kidney disease and inflammation as measured by CRP levels. And you could see that in a dose-dependent manner, again, IL-6 inhibition with ziltivekimab could reduce CRP levels, could reduce fibrinogen levels, and it also actually increased LDL cholesterol and triglycerides, but at least the profile based on ApoB to an ApoA1 ratio, as is shown here, was not significantly affected. So based on these results, he initiated now the ZEUS trial that is ongoing, which includes 6,200 patients with atherosclerotic cardiovascular disease and chronic kidney disease stage 3 to 4 and inflammation, and are randomized into either receiving ziltivekimab or a placebo control. And we will be looking at major adverse cardiovascular events and renal disease progression with results that are expected now in October of 2025. So there's a large variety of different anti-inflammatory drugs that have now been shown to be beneficial or even have been shown to have potential cardiovascular benefits that inhibit cytokines such as interleukin-1 inhibitors or interleukin-6 inhibitors, while, for example, TNF-alpha blockade does not show any effect. And others that are more broad, like colchicines, and are being tested, and there's additional ongoing clinical trials that look at the efficacy of colchicine as well. Preclinically, of course, at the preclinical stage, an even larger amount of different drugs are available. Could you put my slides back on, please? Are available that also try to interfere with innate immune signaling, be it the inflammasome itself or be it signaling through receptors that are pro-inflammatory in macrophages and prevent macrophage activation or the recruitment of macrophages. But there's also more and more interest in potentially targeting the interaction between macrophages and the adaptive immune system by, for example, inhibiting co-stimulatory molecules. And many of you know that actually checkpoint inhibition has been very successful in cancer, where you try to unleash potentially the activity of T cells, but this would be the opposite. You would actually inhibit certain checkpoints to dampen this immune response. And why could this be interesting? This could be interesting because we know that patients with autoimmunity, for example, lupus or rheumatoid arthritis, have a much higher risk of developing cardiovascular disease. And this recent analysis of actually 22 million individuals in the UK and 19 autoimmune diseases has shown a clear association that patients who have autoimmune diseases with increasing manifestations of autoimmunity have a significantly higher risk of developing particularly atherosclerotic cardiovascular disease. So that makes sense, as the adaptive immune system is clearly involved also in the atherosclerotic disease process. Chiara Gianarelli has shown that patients with symptomatic carotid plaques, that these plaques contain more activated pro-inflammatory T cells. So therefore, these could be really good targets. And considering that adaptive immunity is involved, we should also consider that this gives us the chance to target antigen-specific immune responses. For example, lipoprotein-associated antigens, such as oxidized LDL, that can be neutralized with specific antibodies, or T-cell-dependent responses that target ApoB peptides, as Andreas has pointed out before, and allows us to make tolerogenic vaccines that specifically target these specific structures. And one final slide, please. Because I think in what we know now is that may give us the potential to add a different type of immunomodulatory therapy in addition to the anti-inflammatory approaches that are more broadly inhibiting inflammation and that show to be effective based on the inflammatory status, which in part, as I've shown to you, are dependent or mediated by somatic but also by germline variants. But we could have maybe more specific immunomodulatory therapies that may be particularly effective in patients where there's a strong involvement of adaptive immunity. And obviously, as Andreas pointed out, maybe when we talk about inflammation in atherosclerosis, we have to look at different facets of inflammatory atherosclerotic diseases. One, there is more adaptive immunity mediated. The other ones have more metabolic inflammation associated, maybe with fatty liver disease, or others that are more associated with obesity. And each of these may require different anti-inflammatory therapies. And for this, again, I come to the same point as Andreas, novel biomarkers need to be identified to specifically identify the type of inflammatory atherosclerotic patient that we have. Thank you for your attention.
Thank you, Christoph, for your excellent, as always, we enjoy your presentations. So we have a question from Professor Ayman.
Thank you very much for your excellent, deep presentation on the past and the future, I think, of our therapy for this very high-risk group of patients. I think it seems like the issue with the anti-inflammatories is that the community, the cardiology community, seems to have, they see the conflicting results from the data. You have the canakinumab that showed a significant benefit, although it was really small, 17%. And then we have the hope, and it's a small percentage, 17%, and it's a very expensive drug. So the hope was methotrexate, an inexpensive drug, acts the same way, would also show a benefit. So the community was disappointed because methotrexate showed no clinical benefit, and even no pathophysiological benefit. On all the markers,
right,
there was no impact. And that sort of made people lose some confidence in the inflammatory theory, and whether it is the primary effector or it's a surrogate bystander. So that's why there was a lot of, let's say, lack of acceptance, and therefore hesitancy for accepting the concept and going forward with colchicine, which, as we know, has been tried in so many different diseases, again, with conflicting results. So therefore, there's a lot of hesitancy.
I think you're making a very important point. I think what we have to consider when we choose people to put on a lipid-lowering therapy, we select patients that have high cholesterol levels. But do we do this really when we look at the patients that would be eligible or that would benefit the most from anti-inflammatory therapies? We have CRP as one biomarker to stratify for these patients. It has not been done in all these studies. It has been done in the CANTOS trial. But we may need even other anti-inflammation biomarkers that allow us to pick these patients. And as I've shown these data, those that have CHIP, there may be some that have germline variants that predispose to increased inflammation, may be those that benefit the most. And if we have ways to identify these, then maybe our results would be much better and it would be more convincing to the community. And I think that's where we have to go. And among the other things, even stratify the inflammatory atherosclerotic cardiovascular disease in different subsets.
Thank you. And you showed us a glimpse into the future with the CHIP and so on. In your opinion, which holds more promise? Which way would you bet?
I think in the end it comes back to the same point that Andreas made. The more risk factors you have, the more you benefit from any intervention. And I think in inflammation it's the same thing. If you have high inflammation, high CRP, and high, like CHIP, which is obviously not always, but is associated with it, and maybe a bad genetic predisposition, then you would be the patient who benefits the most. And I think maybe Andreas would agree with that.
Actually, we are very late, so we need to move on, but I have one last question for a very quick answer. So age comes with inflammation. You showed CHIP has more inflammation. Is CHIP like a sensor for our internal aging clock?
Well, it seems like it. I mean, it is, but the question is, if it is, you're saying if, yeah, I don't know. I have no answer, but it's clearly associated with age. And those individuals that have CHIP at an early age, as I showed, are in the cardiovascular risk group. So that is an interesting observation. So maybe they have aged early or sooner.
Excellent. Thank you, Christoph.